Hi there. My name is Dr. Lindsay Kuo, and I'm an endocrine surgeon and assistant professor of surgery at the Temple University Lewis Katz School of Medicine. And I'm going to talk today about primary hyperparathyroidism, a little bit about secondary and tertiary disease as well, but predominantly primary. For those of you who are listening to this in the far distant future, I'm recording this for the residents and associate section of the American College of Surgeons virtual curriculum in the setting of the COVID-19 pandemic, which means I'm recording this from home. So apologies in advance if my toddler and or dog make it onto the audio at some point in time. I have nothing to disclose. We'll start with the basics: anatomy, physiology. But we're not going to get too much into any of this because a lot of this is really well done in your textbooks, and there's not a lot more that I can add. The vast majority of us have 4 parathyroid glands, 2 on each side, an upper and a lower, and each gland is the size of a lentil or a grain of rice, and they're typically golden brown in color. The average parathyroid gland weighs about 30 to 40 milligrams. In the normal position, the glands can be found within 1 centimeter of the insertion of the recurrent laryngeal nerve. So in general, they're both located on the posterior surface of the thyroid. The superior gland is derived from the 4th branchial pouch and is generally located anterolateral to the nerve on the posterior thyroid midpole. The inferior gland, which is derived from the 3rd branchial pouch, is located anteromedial to the nerve on the posterior aspect of the inferior pole of the thyroid. Now, I picked this particular image to represent this anatomy because I think it actually, to a good degree, shows where the parathyroid glands are in relation to the nerve. So these anteromedial and anterolateral positions are all described in relation to the nerve, and it's really important to note that the nerve itself travels from lateral to medial as it rises up in towards its insertion point. So it's not as though the superior parathyroid is so much farther lateral than the inferior. It's really just using this information in relation to the nerve to help you determine what parathyroid you are looking at. But again, in their classic positions, they're both very close to the insertion point of the nerve. The superior gland is sort of, again, near the actual nerve insertion point, maybe just a little bit superior to it, and the inferior gland is a little bit more inferior to that. Both of these glands receive their blood flow from the inferior thyroid artery. And here we can see the common ectopic locations of the parathyroid glands. So the ectopic locations refers to the fact that as the parathyroid glands travel during embryogenesis, they can actually end up residing somewhere else in their classic position. And ectopic glands are found in anywhere from 10 to 20% of patients, although the numbers might actually be higher just based on the actual study that we're looking at. So let's look at the different ectopic glands. The superior glands, which are shown in the leftmost image, travel a shorter distance embryologically, and therefore their location is a bit more predictable. I've circled the most common location of the superior glands. The vast majority of the superior glands are located on the posterior surface of the thyroid, either on the body, and then the next most common area is sort of on the posterior aspect of the superior pole. Retroesophageal locations can also be common, and you see in the image there that sort of blue arrow showing the path of the superior parathyroid glands as they travel. The inferior glands are shown in the rightward image, and they travel a farther distance embryologically, and so therefore they're more likely to be in unusual or unpredictable locations. So the normal position is highlighted there. Again, I've circled it, and in both of these images, the thyroid is sort of rotated medially. So the lower gland is highlighted there, and the most common second and third locations of the inferior gland are the thyrothymic ligament and then the thymus. So that's where you should start to think if you can't actually find your inferior gland. Both glands can also be located very high in the neck or very low down in the mediastinum. Glands can also be intrathyroidal. If the glands are intrathyroidal, they're most likely to be superior glands. And here we're looking at the normal biofeedback loop and physiology of parathyroid hormone. So the parathyroid gland senses a decrease in serum calcium via the calcium sensing receptor, and then this triggers parathyroid hormone synthesis and release. The parathyroid hormone itself acts in 3 ways to increase the serum calcium. The first is by stimulating osteoclasts of the bone to lead to increased bone resorption. In other words, you're releasing calcium into the blood from the bone. Number two is it acts on the kidney, and the first way it acts on the kidney is actually increasing the hydroxylation of 25-OH vitamin D to 125-OH vitamin D. This increased 125-OH vitamin D then works in the small bowel to help absorb the calcium that is being consumed, and this is done in the small bowel. And then also in the kidney, the increased calcium absorption and phosphate excretion in the distal convoluting tubule work to increase this body's serum calcium and increase the urinary phosphorus. In normal feed people, this is done in a biofeedback loop. So your PTH activity is stimulated by low calcium and suppressed by high calcium. What I always tell patients that this is like a thermostat, and I use the idea of a thermostat in the body's temperature to help them understand that the low calcium stimulates parathyroid hormone and high calcium will suppress it. And that's often a really good way to explain this to patients. So as we move into the clinical aspects of this lecture, I'm just going to use a sort of actual very classic example of a patient presenting with primary hyperparathyroidism. And in fact, she's the first patient I ever had as an attending. So patient FP, she's a 37-year-old woman who had incidental hypercalcemia seen on her labs performed by her primary care physician. She had been experiencing significant fatigue and mood changes over the past 2 years. On her labs, her calcium was 10.5, with the upper limit of normal in this assay being 10.2. So what's your differential diagnosis, and what are your next steps to help differentiate between these diagnoses and make the right diagnosis? So primary hyperparathyroidism, which is the meat of this talk, it's actually relatively common and it affects about 100,000 patients in the United States each year. It is generally a disease diagnosed more in women than in men, and it is more often found in people aged 60 and over. And it's actually a very simple disease. Primary hyperparathyroidism is caused by the autonomous secretion of parathyroid hormone from the parathyroid glands, and this leads to hypercalcemia. And that's the heart of every problem we have related to the primary hyperparathyroidism. What I didn't understand for a very long time as a resident, and what I learned during fellowship, and what I think is absolutely crucial to understanding these patients, is realizing that this is actually a chronic disease that affects multiple organ systems. It may seem small or unimportant, but what we know about hyperparathyroidism is that if it goes untreated, it can have dire consequences. And if it is treated, then you have the opportunity to cure chronic diseases, which is not something that a lot of surgeons can really do. So what are the symptoms associated with primary hyperparathyroidism? We all learned the stones, bones, groans, psychiatric overtones, mnemonic in medical school, and this really actually does hold true, but we're going to dig into it a little deeper. So let's take the stones. So this often refers to kidney stones, and the kidney stones themselves stem from having a high serum calcium, and this causes calcium spilling over into the urine. Kidney stones are fairly common. Anywhere from 7 to 20% of patients with primary hyperparathyroidism develop kidney stones. And not only are these painful and can affect individual quality of life, but there can also be significant downstream consequences, such as obstructive uropathy and sepsis. And so, in fact, I actually had one patient who, when I evaluated him for his primary hyperparathyroidism, he had in a PICC line and in bilateral percutaneous nephrostomy tubes because his kidney stones had totally obstructed his urinary outflow, and he'd had multiple septic events. High urinary calcium can also lead to polyuria, and then patients then experience polydipsia as a way to manage their polyuria. Now, importantly, parathyroidectomy can actually decrease stone formation, and so that's really helpful to know and a way to tell patients that this is one reason we really need to be addressing this problem. The bones. Without treatment, patients with primary hyperparathyroidism will develop osteoporosis, and you have an increased fracture risk as a result. Now, again, if we review our pathophysiology, we know that the parathyroid hormone stimulates osteoclast, and you get increased bone resorption, and this will continue and continue and continue. And there's no osteoporosis medication that can really overcome this. However, with parathyroidectomy alone, patients will experience an improvement in bone density at 1 year postoperatively, and these improvements will continue for a decade. Parathyroidectomy patients will also experience a reduced risk of fractures, but in contrast, without treatment, patients will develop end-stage bone disease, so osteitis, fibrosis cystica, and brown tumors. Patients with primary hyperparathyroidism can present with abdominal pain, constipation, and reflux. And last but definitely not least, these patients present with a variety of neuropsychiatric symptoms. I always ask patients about their fatigue and energy level to start with, as well as difficulty sleeping and mood changes. The fatigue itself can be extremely debilitating. Um, Patients can oftentimes just really feel that this is something they just need to learn to live with. Memory changes are often very common as well, and again, because most of these patients are in their 60s or older, they've attributed these memory changes to just simply aging. Um, Specific questions I will often ask are, do you feel like you go into a room and you don't remember why you're there? Or do you put something down and do you not know where you put it or what you did with it? Do you have word finding difficulty? So a lot of times these are short-term memory issues, or they have difficulties with naming or identifying like a phone number. Um, Again, I want to ask all of these questions. I will often also ask about, do you feel like your mind is in a fog or do you have difficulty concentrating? Patients don't always uniformly answer yes to all of these things. It may be yes to one or two and no to the rest. So again, there's no one classic presentation, so it's important to ask a variety of these questions. And I cannot emphasize enough how important it is to ask about these neuropsychiatric symptoms. You don't know that all of these problems are related to the hyperparathyroidism, but a lot of times they are, and you want to understand what you can maybe offer the patient in terms of hope for the future. And I had a patient about a year ago now, and she was actually a nurse in my hospital. She's very public about this on social media, so I don't think I'm outing her in any way, but she's very young and she's an ER nurse, and she had hypercalcemia in her labs for 2 or 3 years, and it was kind of just brushed aside. And she began experiencing significant difficulties with concentration and her memory. And she finally sort of put her foot down and made her PCP work her up for this when she realized she could no longer remember the steps of like the ACLS protocol. It was limiting her life that much. And so we did her operation, and within 2 weeks, she sort of regained all of her normal memory, her normal energy, and she told me that she had felt like she had a new lease on life. And these were her only major symptoms. She didn't have kidney stones or osteoporosis, but she felt like the operation itself had really changed her life dramatically. And that's incredibly gratifying, and that's why I always ask these questions for patients, just to see how they might be affected by this disease. What are some other but lesser known but very important consequences of primary hyperparathyroidism? So patients can develop nephrocalcinosis, in which the kidneys themselves become calcified, and this will cause worsening renal function. So anywhere from 15 to 30% of primary hyperparathyroidism patients will develop a decreasing GFR. And without parathyroidectomy, the renal function will continue to worsen. There's no evidence yet that parathyroidectomy will improve their GFR, but it should actually stabilize it where it is. Hyperparathyroidism also has a negative effect on patients' blood pressure. In patients with both hypertension and hyperparathyroidism, parathyroidectomy will lead to a decrease in both their mean arterial pressure and the number of antihypertensive medications taken when compared to patients who do not have parathyroidectomy. We know that hyperparathyroidism has a multitude of negative effects on overall cardiovascular health. So patients with primary hyperparathyroidism have higher rates of cardiovascular mortality than patients without the disease. And this is due to cerebrovascular accidents, arrhythmias, myocardial infarctions, and heart failure. The literature is split on the benefit of parathyroidectomy to reduce the rate of these cardiovascular events. Some literature from Europe suggests that parathyroidectomy can reduce these rates back to normal population rates, but some data from the United States disagrees. Regardless, we can see that the effects of these diseases are pretty massive and can affect a variety of incredibly important organ systems, and so this is not as a disease that can or should be ignored. Okay, so how do you diagnose this problem? We've just reviewed the symptoms. How do you actually diagnose this problem if a patient comes to you in the office with maybe a high calcium level, maybe a high parathyroid hormone level, maybe both? What are you going to do? So most commonly, these patients will be presenting to you as surgeons with hypercalcemia, and the image I'm showing here has a calcium of greater than 10.5 as diagnostic. Just be sure to check whatever lab assay the patient's lab is using, because the upper limit of normal will be different from based on lab to lab. And so what you want to do with this patient is you want to always check their labs. If they haven't gotten a repeat, you should get a repeat. You want to make sure that your calcium and your parathyroid hormone level are drawn simultaneously. Drawing them a few days apart or even a week apart is not necessarily representative because the calcium and parathyroid hormone levels can fluctuate. So you want to make sure that you get a simultaneous draw. And so that's what you're going to use initially to confirm your suspicions or to confirm what somebody else has sent the patient to you with. And you want to take a very thorough history and also do a physical. So you want to make sure you've ruled out the other potential causes of hypercalcemia, so medication related, like thiazides. You want to look at possible malignancies. And you want to evaluate from the signs and symptoms that we just discussed at length. You want to see if they've had a DEXA scan to evaluate bone density. You want to ask them what their family history is. Do they have any family members with hyperparathyrodism? If they don't know that, you want to ask about hypercalcemia or kidney stones. So again, let's say you repeat these labs and you have a high calcium and your parathyroid hormone level is high as well, and the patient's history is sort of classic for primary hyperparathyrodism. There's no red flags there. So how do you diagnose this? A high parathyroid hormone level is anything greater than 65. This is what we call classic disease, so a high calcium and a high parathyroid hormone level. A normal parathyroid hormone level ranges from like 11 or so to 65, and this ranges the potential for normal hormonal disease, which we'll discuss. I'm not going to discuss what happens if you have a low PTH. That's sort of a different conversation. But let's say you have this patient who probably has primary hyperparathyrodism. You then want to, again, sort of confirm this disease or confirm this diagnosis and by ruling out other things and do some thorough testing to make sure the patient's ready for an operation. So you want to check a 25 hydroxy vitamin D just to see what their vitamin D levels are. And you want to check also a 24-hour urinary calcium and urinary creatinine. So again, what is the vitamin D relevance? If it's too low, it might indicate a possible secondary disease. And the 24-hour urinary calcium and creatinine are helpful to evaluate for familial hypercalcemic hypocalciuria, or FHH. So FHH often has a urinary calcium of less than 100, although that finding alone can have a multitude of explanations. A urinary calcium to creatinine ratio of less than 0.01 is also indicative of FHH. But FHH is incredibly rare, so if you get a 24-hour urinary calcium and it's less than 100, I would actually recommend repeating your 24-hour urinary calcium after having the patient on 2 weeks of a normal calcium diet, but no supplements. You can also get a phosphorus, and this can also help you with your diagnosis because the chloride to phosphorus ratios can be greater than 33 to 1. You also want to be taking a thorough look at how your patient's calcium has been in the past. Has there been a trend? What else, again, what other explanations can there be for this? But it's really important to be able to evaluate the patient's labs and make these diagnoses because this is how the vast majority of your patients will present to you. 30, 40 years ago, patients presented with extreme disease, but now patients are presenting with more clinically mild but biochemically obvious disease. So as I mentioned earlier, classic disease is characterized by having an elevated calcium above the upper limit of normal, as well as a concurrently elevated parathyroid hormone level above the upper limit of normal. But there are two disease variants that we will be discussing briefly. I don't think your text goes into these quite as much, and we're not going to spend a lot of time, but you should be aware of these. So one is normal hormonal disease, and one is normal calcemic disease. And we are diagnosing these biochemically milder variants because we're seeing more and more patients referred for hypercalcemia or for bone health assessment. So we're seeing patients who may have slight disease variants, and up to anywhere from 5 to 25% of patients have one of these biochemically milder forms of the disease. So what is normal hormonal disease? So this is a class characterized by having an elevated calcium and an inappropriately normal parathyroid hormone level. So again, normal is anywhere from 11 to 65. As we discussed earlier, there is a biofeedback loop. So if the calcium level is very elevated, your parathyroid hormone level should be suppressed, so it should be very low. In other words, it's not normal to have a calcium of 11 and a parathyroid hormone level of 45 or 50. Instead, your parathyroid hormone level should be very low, closer to the lower limit of normal. Now, there is no one cutoff that everyone uses to diagnose what is primary hyperparathyroidism or normal hormonal disease. A lot of people will use a parathyroid hormone level of roughly 20. When presented with a patient who has elevated calcium and a high normal or non-suppressed parathyroid hormone level, you do need to rule out other causes of calcium elevation, like thiazides, lithium, calcium supplementation, or FHH. But most notably, biochemically mild disease in this format does not equate to symptomatically mild disease. So 70 to 95% of these patients with normal hormonal disease have the classic symptoms, and patients will have similar or higher rates of osteoporosis, kidney stones, and neuropsychiatric symptoms when compared to the patients with classical disease. What is normal calcemic disease? So normal calcemic disease is characterized by a normal calcium level and an elevated parathyroid hormone level. And this is something I would, be concerned about happening when the parathyroid hormone level is slightly higher to somewhat higher than normal, maybe 65 to anywhere like 110 or 120. And then the calcium level itself is not 8.5, it's maybe the upper half of 9. So when you have this, it's obviously very confusing for secondary disease, and so we'll talk about that in a little bit. So you need to rule out other causes of elevated parathyroid hormone levels, so vitamin D deficiency, malabsorption, renal insufficiency, loop diuretics, bisphosphonates, lithium, because these are all problems that can actually increase your parathyroid hormone levels. That said, when you fully diagnose this disease, these patients do have similar or higher rates of osteoporosis and kidney stones and similar rates of cardiovascular events compared to patients with classic disease. Now, this might be a little bit of selection bias because in patients with classic disease, they're not even being evaluated if they're not being asymptomatic, but it's important to realize that these patients do have associated symptoms, and they can also experience improvements in bone density following surgery. So, what are these variants? Are these diseases that will eventually progress to being classic disease? Will they always stay the same with their current biochemical profile? I don't think anyone really knows the answer to that. Of the normal calcemic patients, 22% of one study developed overt hypercalcemia over 4 years while on medical management. But there's other thoughts that perhaps people have different set points where their normal levels of calcium are. Normal hormonal disease is widely recognized to be a variant and may be a precursor. So people very much accept this as a real thing that is its own sort of very similar disease entity. You should basically, however, once you have identified these patients, treat them like your primary classic disease patients. So when do you operate? So firstly, operating is the only treatment option for these patients. There is no medication that can cure this problem. Some medications may be able to address some of their symptomatology, but nothing else will actually manage this disease. An operation is the only solution. And secondly, I'd like to focus on the fact or highlight the fact that we are talking about when to operate based solely on having discussed the patient's presentation and their labs. And that's because that's all we actually need to factor into account when making the decision about an operation. What are the patient's signs and symptoms, and what are their labs? So anyone who has what we call symptomatic disease gets an operation, with the caveat that the official definition of symptomatic disease is actually very narrow, and this is a definition that's put forth by the National Institutes of Health. So symptomatic disease is disease that used to be symptomatic back in the 1960s and 70s, and this is how patients presented very late in this disease process. So patients who have kidney stones causing problems, osteitis, fibrosis cystica, and hypercalcemic crisis. These are the official symptomatic disease patients. But going forward, when I talk about patients who have symptoms, please remember it doesn't refer to just this small cohort. So as I mentioned, the NIH says that those symptomatic patients should all get an operation. However, as more and more patients are being diagnosed with this problem because of regular laboratory testing or evaluations for bone health, physicians about 30 years ago recognized that there needed to be a better understanding for when to operate for patients with asymptomatic disease. Asymptomatic referring to all patients who don't have official symptomatic disease. So in 1990, the NIH established some guidelines for asymptomatic disease, and these have been updated a handful of times over the last 30 years. And I put a little timeline here. We're not going to get into the details of what changed with each iteration. But the most recent iteration was published in 2013. And here are the criteria put forth by the NIH. So the criteria for quote-unquote asymptomatic patients, they should receive an operation if they have symptomatic kidney stones or fractures, a calcium greater than 1 milligram per deciliter above the upper limit of normal, a T-score of less than 2.5 on a DEXA because this indicates osteoporosis, creatinine clearance of less than 60 milliliters per minute, a 24-hour urine calcium of greater than 400 milligrams per deciliter, as well as an increased stone risk profile, nephrolithiasis, nephrocalcinosis, or vertebral fractures on imaging, so again, imaged kidney stones, calcinosis, or vertebral fractures, a patient in whom surveillance is not desired or not feasible, surveillance referring to the need for serial labs, DEXAs, and maybe plain films to evaluate for kidney stones, and age less than 50, because these patients would incur a significant amount of cost due to surveillance over the years. More recently, the American Association of Endocrine Surgeons published in 2016 guidelines for the definitive management of primary hyperparathyroidism. And in that publication, they also addressed some guidelines on when to operate for asymptomatic patients. And by and large, it really overlaps with the NIH guidelines. I think they're a little bit more simple and straightforward. But they also recommended that you consider or you perform a parathyroidectomy when there's neurocognitive or neuropsychiatric symptoms that are attributable to primary hyperparathyroidism, and that parathyroidectomy may be recommended in patients who have cardiovascular disease in order to mitigate future cardiovascular sequelae. So they've added in a few additional indications here. I think they're very important because, again, you can see a really dramatic change in people's neuropsychiatric symptoms following parathyroidectomy, and these are patients in whom they desperately want improvement. And again, we can understand that there are some downstream consequences on the cardiovascular system that may not be reversed, but may be alleviated the progression of a following parathyroidectomy. So what about osteopenia? That's something that really wasn't addressed in either guideline recommendation. So should we be operating for osteopenia? As you know, osteopenia is sort of like a step on the road towards osteoporosis. And what we know about this disease process is that it stimulates osteoclasts and there's no medication that can really combat it. So a really excellent question is, should we be operating for osteopenia? So officially, there's no recommendations like this in the guidelines, but a lot of endocrine surgeons, myself included, will operate for patients who have osteopenia to prevent them from developing worsening disease. So again, once you've met the patient and looked at their labs, that is when you make your decision to operate based on their biochemistry and their overall presentation. And once you've made that decision to operate, then you figure out what imaging you should get. And imaging is helpful, but I cannot stress this enough. Localization with your preoperative imaging is in no way necessary to operate on a patient. So a localization is not necessary. It can be very helpful if you can identify a parathyroid gland preoperatively. And ultrasound has been one of the mainstays of preoperative localization over the years. And here we're looking at a parathyroid gland that's posterior to the thyroid. And you can see it here as a round hypoechoic structure with a clear border between itself and the more anterior thyroid gland. Ultrasound has been a mainstay, again, because it looks at the parathyroid, but it also looks at the surrounding thyroid and evaluates for nodular disease. Nodular disease is present in anywhere from 12 to 67% of hyperparathyroidism patients. And so for this reason, the American Association of Endocrine Surgeons recommends that all patients undergoing parathyroid surgery first receive a neck ultrasound. The benefits of neck ultrasound: again, it is low cost, there's no radiation, so no risk of injury to the patient. However, it is somewhat limited. It's operator dependent. It's more likely to miss small glands or glands that are very deep in the neck. It'll miss a lot of times ectopic glands depending on how good the ultrasonographer is, and it won't find any glands that are in the chest. Overall, the sensitivity has a range in the literature anywhere from like 50 to 95%, with a PPV of about 93. Sesame B scintigraphy addresses ectopic glands and is very good at looking for the presence of glands in the chest. There are a variety of sesame B scintigraphy scans, and I'm not going to discuss them all in depth. They can use different types of actual imaging. Are they planar or axial? Different types of radioisotopes. There's a whole variety, and this is not the forum to discuss all of them. However, the most intensive is a SPECT CT, in which the scintigraphy is overlaid with 3D CT scanning. Each institution, though, has its own protocol for what they like to use. The downside of sesame B scintigraphy is that it is very limited in patients who have multi-gland disease or small glands, and if a patient has concurrent thyroid nodular disease, that can sort of obscure any of the good views. It also entails some more radiation exposure, and it can be sometimes very lengthy or inconvenient. The sensitivity for SPECT-CT also ranges from 28 to 98%. Scintigraphy, all comers, has about an 80% sensitivity. It has a pretty good positive predictive value overall, so if you see it on scintigraphy, that's usually it. Now, when you combine the two modalities, you will get an increase in your positive predictive value, and that's when they're called concordant. And here is a table from a recent New England Journal of Medicine summary article on primary hyperparathyroidism, and it highlights 4 imaging modalities used. So ultrasound and sesame B with SPECT-CT. Their sensitivity and PPV values aren't quite what I quoted you earlier. I don't really think that's as relevant. It does a nice job of listing some of the highlights and the negatives of each imaging modality. This table also shows some data on 4D CT and MRI. We're going to talk more about 4D CT in a moment. MRI can be used in a lot of patients, however, it's very expensive and it's very lengthy. So it's often reserved for patients who have recurrent or persistent disease or who cannot get other imaging for a variety of reasons. 4D CT is a newer imaging modality. It's been around for about 15 years, although it has become much more popular in the last 5 or 6. The benefit of it being a CT is that it can look in the chest, and it also provides you more anatomic information in general. Studies have shown that 4D CT has improved localization for patients who have multi-gland disease, patients with normal calcemic disease, patients who are non-localizing on other imaging modalities, patients with ectopic glands, small glands, or recurrent or persistent disease. So it's overall very useful. Why do people not use it? For one thing, if somebody has a really good imaging modality at their institution that they're really happy with, they may not feel that 4D CT as much. Additionally, there was some concern several years ago about the added radiation exposure due to 4D CT. However, that concern has largely been obviated by the fact that 4D CT has the same overall carcinogenesis risk as scintigraphy, or it's incrementally more. However, there is some additional cost up front due to it being a CT scan, but a lot of times that can be made up on the back end with decreased OR time. So what is a 4D CT? So it is a CT of the neck with IV contrast, and the fourth dimension is time. And so there's a variety of protocols, but one of the most common ones is a non-contrast initial scan. Then you give a bolus of contrast, and then you do an arterial contrast set of images at about 25 or 30 seconds, and then you follow that with a venous or washout phase at about 80 to 90 seconds. And this creates 3 sets of images. There are some 4-phase studies, there are maybe some 2-phase studies, but 3 phases is probably the most common. And the goal of this is to look for different arterial and washout patterns of the parathyroid and the thyroid. So the parathyroid glands will have a mean arterial attenuation of about 130 to 180 Hounsfield units, so roughly the same enhancement as the thyroid. Then the delayed phase will show some washout, so it'll be darker than the thyroid. And the non-contrast images will have the least amount of enhancement. So I look for the enhancement as well as the radiologists. What you can oftentimes offer that the radiologists may not always get is understanding what thyroids normally look like in real life, and therefore what is not a normal thyroid appearance. So shape, location, and also contour. Location is important because the radiologist may not always be looking at ectopic locations, and contour because, again, a thyroid does not necessarily always bulbous or asymmetric in a certain way. Oftentimes you can see a polar feeding vessel as well. So let's take a look at some images, and this is that patient we were talking about earlier, FP. And so we see here, this is a coronal view. We can see here the thyroid itself lighted up on both sides of the trachea, and then inferior to the right thyroid lobe is actually one area of enhancement that's concerning for a parathyroid gland. You can see that there's a degree of anatomy here that you don't fully get on the ultrasound or the SPECT. So again, this is our coronal images. The far left one is the arterial enhancement, and I've circled the lesion in question. So again, an extra thyroidal mass inferior to the thyroid lobe. It's not really a classic position, but does enhance a lot on the arterial images. Then it washes out somewhat more than the thyroid does in the venous phase, which I've also circled here. And now on the far right, we actually have the non-contrast images, which show the least amount of enhancement of this mass. So the enhancement pattern is very classic for a parathyroid adenoma, but also we all know that there really should not be anything else in the neck at that point. There should be no other mass-like structure. So to me, it was the location, size, and shape of this mass as opposed to the enhancement pattern that really made it very clear. But again, the major takeaway from this lecture should be that localization is not necessary for making a decision to take a patient to the operating room. It simply helps you decide what kind of operation you're going to do and may shorten your operation time. Okay, so time to the operation itself, because you've seen your patient, you made your diagnosis, you determined that the patient met guideline and criteria for a parathyroidectomy, then you got imaging that maybe pointed you in the right direction. So, time to operate. What are you going to do? So, a quick detour back into the pathophysiology of this disease. How many glands are abnormal? The vast majority of patients with primary hyperparathyroidism have single adenomas. This is present in about 85% of all comers, although some single institution studies will have varying percentages based on their particular patient population. Double adenomas make up about 7%, multi-gland or four-gland hyperplasia, another 7%, and roughly 1% for parathyroid carcinoma. So the vast majority of patients with primary hyperparathyroidism have one abnormal gland. But you don't always know how many abnormal glands the patient has before going into the operating room. And even if you think you do, you should probably still be a little bit suspicious. So when you take someone to the operating room, the goal is to remove all of their abnormal parathyroid tissue. So if that's one gland, you're going to remove one. If it's multiple glands, you're going to remove the multiple glands. If it's all four, you'll remove 3.5 glands. So how do you know when you've removed enough glands? There are a couple of techniques, but the most common one is to use intraoperative parathyroid hormone monitoring. And this is a process by which you check your parathyroid hormone level at the beginning of the operation, and then you check it again after you've removed the abnormal parathyroids. And the goal is to see the parathyroid hormone level drop by at least 50% and into a normal range. This is called the Miami criterion, and this is how you can predict operative cure. There's no one right or wrong way to draw your intraoperative parathyroid hormone levels. Everyone will have a different protocol, but you should basically use one protocol and stick to it. So again, the goal of surgery is to remove the abnormal gland. So if it's a single gland disease, you resect just that gland. If it's multi-gland disease, again, 2 glands, you'll resect both. If all 4 glands are abnormal, you'll resect 3.5 glands. You do the operation that you need to do when you can't always know in advance what operation that's going to be. So in the text that accompanies your SWOR curriculum and a few other places and the internet and a lot of discussion, you'll see a debate about minimally invasive or focused parathyroidectomy. And these terms refer to preoperative localization of the abnormal parathyroid gland, using that localization to make a smaller incision in the operating room, identifying just that abnormal gland and not doing any more exploration. So this technique is very dependent on using intraoperative parathyroid hormone monitoring or gamma technology, which I don't personally use. The benefits of this minimally invasive or focused operation are a smaller incision, Potentially a shorter operation, less risk of iatrogenic injury, and less scar tissue formation. However, in this operation, you don't actually see any of your other glands, so you never can know for sure if there are any other normal or abnormal glands present. The alternative approach is a bilateral or four-gland exploration, in which you look on both sides of the neck and identify as many normal and abnormal parathyroid glands as possible, ideally all four. Now, this is a process that's absolutely necessary for any multi-gland disease. But some surgeons will do this for single gland disease only, the benefit being that if you see normal glands, then you can be sure that you removed all the abnormal ones. So it's really difficult to parse out how good a focused or minimally invasive approach is, and there's a range of data on the success of focused parathyroidectomy. And I don't think at this point there's any way to say that one approach is better or worse than another. It really depends on the patient, including their preoperative imaging, their particular case, and what you've seen in the operating room, and the surgeon's experience. So after your operation, how do you take care of this patient? Um, Most patients at this point in time go home the same day following their parathyroidectomy, and they oftentimes will go home on calcium supplementation and sometimes also vitamin D supplementation as well. The calcium supplementation is in the form of calcium carbonate or calcium citrate. Some people will also send them home on calcitriol, or the brand name of which is Rocaltrol, which is an activated vitamin D. So a sample regimen here is like elemental calcium, 600 milligrams, 3 times a day, plus maybe daily small dose of calcitriol. That's just a sample regimen. Again, everyone has their own different processes, but the goal is that you're giving them enough calcium to get them through an initially hypoparathyroid time period, in which they may also have a degree of hungry bone syndrome, in which their bones are sort of sucking up all the available calcium in their serum. You want to make sure the patient has good education about the signs and symptoms of hypocalcemia. They have to perioral numbness or tingling, digital numbness or tingling, and even muscle cramps in the hands and feet. So, what are the complications that you need to be aware of related to parathyroidectomy? The most common one is something that we just referred to. Hypocalcemia is the most common complication. And again, this occurs because you've rendered the patient relatively hypoparathyroid. The remaining parathyroid glands may be relatively suppressed, may not be acting very well, and you may also have hungry bone syndrome, again, when your bones are now attempting to suck up all the calcium in your patient's serum. So this is usually a transient problem and lasts only a few days, and oftentimes it's fairly mild. Patients again experience some perioral numbness or tingling, followed by digital paresthesias. Again, most severe is muscle cramping. This can develop into seizures. So this is why you need to send patients home on a calcium supplementation regimen and give them good education, and then have a good follow-up process for them. Iatrogenic recurrent laryngeal nerve injury can also occur, and this is generally very rare and usually is a stretch injury because of retraction on the thyroid. So patients will present with their classic hoarseness, which is generally more of a breathiness than a true hoarseness, and that's just because this nerve is stretched, and you can scope them to confirm this. They may also have some difficulty swallowing liquids. This will generally last about 6 weeks or so and will resolve on their own. Bleeding is incredibly rare. Postoperative infection is incredibly rare as well. But how do you know that your operation was successful? So let's say you took out one gland, your parathyroid hormone level fell appropriately. How can you be sure you actually fixed this patient? And it's something that you should discuss with patients pre-op. Persistent disease is essentially an operative failure. So you don't cure the patient at your initial operation. Their calcium levels never normalize. So again, this disease persists. Recurrent disease refers to a situation in which the calcium levels initially normalize, but over time, at least at a window of 6 months or more, the calcium level once again becomes elevated. And the rates of operative failure, again, range based on the study and the individual surgeons included in the study, but occur anywhere from about 5 to 10%. So let's return to that patient we first discussed at the beginning of our lecture. So 37-year-old woman, incidental hypercalcemia, seen on labs at our primary care physician. She presented to you with significant fatigue and mood changes over the past few years. Her labs showed a calcium of 10.5. This is how she comes to your office. In your office, again, you take a thorough history. She reports this extreme fatigue, which she had attributed to taking care of her infant. And she's also had some overall mood changes, generally some sort of depression, which her mother also endorsed over the past 2 years. No family history of any related problems. You get repeat labs. Her parathyroid hormone level is in the 120 to 140s. Her calcium is consistently elevated or at the upper limit of normal. Her 25 OH vitamin D is 27. Now, the low end of normal is 30, but oftentimes this will be a little bit low in patients with primary disease. Her creatinine is normal, and her 24-hour urine calcium is classic. That is 450. So based on all these factors, you make the decision that she needs an operation. She has this problem, and she has multiple guideline criteria, in particular her age and her elevated urinary calcium. You get imaging, you get your thyroid ultrasound that shows no parathyroid adenoma and no thyroid nodules, and you get that forced VCT scan that we looked at earlier. And this localizes to the right inferior neck, and it's actually just below the level of the clavicle, which is why you couldn't identify it on ultrasound. In the operating room, you find this enlarged right lower parathyroid gland in its ectopic position as predicted by the preoperative imaging, and it is very large, it's brownish reddish, and it's roughly the size of a cherry, actually. And her intraoperative parathyroid hormone drops significantly. She goes home the same day, no issues postoperatively with hypocalcemia. You see her for post-op visit 2 weeks later, and her fatigue has remarkably improved, and she's in much better spirits. So, operative success. So let's pivot a little. Patient SH, 75-year-old man, comes to the ED with increasing fatigue over 4 weeks. He has some depression. He reports bone pain, but no constipation, no memory changes, otherwise no major issues. But it's really this fatigue and sometimes the bone pain that prompted his arrival to the emergency room. On labs in the ED, his calcium is 17. The parathyroid hormone level is almost 1600. The creatinine is elevated, his vitamin D is normal, his 24-hour urine calcium is 614. You're consulted, you do a thorough chart review. 1 year previously, his calcium was also elevated at 11.3, and his creatinine was normal. He has a history of hypercalcemia, but no other significant surgical, medical, or family history. What do we do next? So first off, it's important to recognize that this patient is presenting in hypercalcemic crisis. His calcium is 17 and he's symptomatic. His creatinine has taken a hit. So we're going to discuss first hypercalcemic crisis. And this might seem like this is a medical issue, which yes, it is. But you should know how to treat it because patients will present like this. And more frequently than you thought. And this was also a scenario that you can easily be asked on your oral boards. So take a moment to read up about hypercalcemic crisis. So what is hypercalcemic crisis? There's a variety of definitions, but basically it's an adjusted calcium of greater than 13.5 or 14 with signs and symptoms of hypercalcemia. So anywhere from 1.5 to 6% of patients will be presenting with hypercalcemic crisis. The most common cause of hypercalcemic crisis is still a single gland adenoma. Again, multi-gland parathyroid hyperplasia, present but less common than adenomas are. A parathyroid cyst can also be reported in the literature. That's essentially when you have an adenoma and you almost like bleed into it and it creates a cyst and this acute elevation in your parathyroid hormone levels. You can also have parathyroid carcinoma. And this happens in about 4.5 to 5% of patients with hypercalcemic crisis. So it's important to note that while any patient having hypercalcemic crisis should sort of trigger your thought process to worry about parathyroid carcinoma and treat the patient almost as if they have it, it is still important to recognize that this is still very rare, and the majority of patients with hypercalcemic crisis will still have a single gland adenoma. So how do you treat hypercalcemic crisis? The first thing you're going to do is give fluid, so normal saline. These patients are going to be dehydrated because the urinary calcium is so high, and so they're peeing out a ton of urine to deal with that calcium level. So they need a lot of fluid. So start hitting them with a bunch of fluid but try to avoid fluid overload or exacerbating a patient with congestive heart failure. You can also give them diuretics, particularly loop diuretics like Lasix. Again, you don't want them to become fluid overloaded, and in particular, the Lasix will block the calcium reabsorption in the loop of Henle. You can also give IV bisphosphonates, and these help inhibit osteoclast action that is triggered by the hyperparathyrodism, and this will help decrease their hypercalcemia. And sort of later in the stage, you can give them hemodialysis or peritoneal dialysis, and these are patients who really have no other options but need their calcium removed from their system in some way. You do this with a calcium-free diazolate. However, this can cause dialysis-related problems. So just if you are a chief resident and you are preparing for your oral boards in the next 6 months, make sure you review how to manage and treat hypercalcemic crisis. So going back to this patient, SH. So this patient was admitted to the hospital from the emergency room, resuscitated with a ton of IV fluids, given pamidronate as well as calcitonin. In the end, was discharged with a calcium of 11. So this calcium normalized and his creatinine is starting to improve. While hospitalized, this patient got imaging that localized the parathyroid gland to the left lower neck on both the sestamivi. You can't get a 4D CT with this creatinine. So the sestamivi and the ultrasound. And the ultrasound showed a 3 centimeter hypoechoic lesion just below the left inferior pole of the thyroid. So concordant imaging. So does this patient have parathyroid carcinoma? The answer is you don't really know. You have treated the patient's biochemistry and they've responded appropriately. So now all you know is you need to take this patient to the operating room and figure out what they have. Now, if we think about parathyroid carcinoma on its own, it classically presents in patients who have an acutely elevated calcium level, who previously had a normal calcium level, and their calcium level is pretty high, 14, 15, 16. They'll also have an extremely elevated parathyroid hormone level. I don't just mean like 150 or 200, I'm talking 600, 700, 800. Something that can clue you into it being parathyroid carcinoma is if they have a palpable mass in their neck. Although I've never personally seen this, I think it's perhaps just one of those words that's triggered more often in examinations. You also want to take into consideration this is an overall healthy patient or a younger patient in whom you would not expect them to have significant parathyroid disease. So if your suspicion is raised for parathyroid carcinoma, which in this situation, that patient we were discussing, you absolutely should have a suspicion for parathyroid carcinoma, you need to take them to the operating room in a somewhat expeditious manner, a couple of weeks. And then in the operating room, that's when you make your decision if they have parathyroid carcinoma or not. This is entirely a clinical decision. It is based on whether or not the parathyroid is adhesed or densely stuck to the surrounding tissues, in which case you do the parathyroidectomy and an en bloc resection of the surrounding tissue, be it a thyroid lobectomy or attached lymph nodes or other fatty tissue. Again, this is an intraoperative clinical decision. Sometimes later on, pathology can tell you if they see invasion into the surrounding structures, but you should still act in the way that is the most safe for the patient at the time, because you will not be able to necessarily go. So, does this patient have parathyroid carcinoma? The answer is you don't really know. You have treated the patient's biochemistry and they've responded appropriately. So now all you know is you need to take this patient to the operating room and figure out what they have. Now, if we think about parathyroid carcinoma on its own, it classically presents in patients who have an acutely elevated calcium level, who previously had a normal calcium level, and their calcium level is pretty high, 14, 15, 16. They'll also have an extremely elevated parathyroid hormone level. I don't just mean like 150 or 200, I'm talking 600, 700, 800. Something that can clue you into it being parathyroid carcinoma is if they have a palpable mass in their neck. Although I've never personally seen this, I think it's perhaps just one of those words that's triggered more often in examinations. You also want to take into consideration this is an overall healthy patient or a younger patient in whom you would not expect them to have significant parathyroid disease. So if your suspicion is raised for parathyroid carcinoma, which in this situation, that patient we were discussing, you absolutely should have a suspicion for parathyroid carcinoma, you need to take them to the operating room in a somewhat expeditious manner, a couple of weeks. And then in the operating room, that's when you make your decision if they have parathyroid carcinoma or not. This is entirely a clinical decision. and is based on whether or not the parathyroid is adhesed or densely stuck to the surrounding tissues, in which case you do the parathyroidectomy and an unblock resection of the surrounding tissue, be it a thyroid lobectomy or attached lymph nodes or other fatty tissue. Again, this is an intraoperative clinical decision. Sometimes later on, pathology can tell you if they see invasion into the surrounding structures, but you should still act in the way that is the most safe for the patient at the time, because you will not be able to necessarily go back with great ease. So let's pivot now and talk about secondary hyperparathyroidism. So obviously this is a condition also primarily of the parathyroid glands. But the reasons behind this disease problem, the biochemistry it presents with, the symptoms the patients have, are wildly different from how patients with primary disease present and what their labs look like. And at the same time, the treatment that you offer patients with secondary hyperparathyroidism is also wildly different than what you offer patients with primary disease. The most common cause of secondary hyperparathyroidism is a low vitamin D level. And there can be a variety of reasons for having your low vitamin D level, but this is the most common reason. Having a low vitamin D level means that you then get a low calcium level, and that stimulates your parathyroid glands to overact. So in the end, your calcium level is roughly normal, and your parathyroid hormone level is slightly elevated. It can be higher, but I generally think of it being roughly in the range of like 65 to 100. And when a patient has a low vitamin D level causing secondary hyperparathyroidism, the only treatment ever is medication to deal with vitamin D supplementation. There are no surgical options. So it's really important to make sure a patient has a vitamin D level assessed so that you make sure you're not operating a patient for a problem that's not going to be fixed with surgery. The reason we are often referred secondary hyperparathyroidism patients as surgeons is for secondary disease caused by end-stage renal failure on dialysis. And these patients present with a normal calcium and an extremely, extremely elevated parathyroid hormone level. And I typically think about parathyroid hormone levels in these patients being at least 600 up to a couple of thousand. So, in secondary disease due to end stage renal disease on dialysis, you get secondary disease because of your kidney function being so poor. So, you have decreased kidney function. This increases your phosphorus and decreases your vitamin D. You have an increased phosphorus. This starts to bind up your calcium. This creates a low calcium as well. Your lower vitamin D level then decreases, or means you have decreased calcium absorption in the small bowel. So then you have a lower serum calcium. And together, your overall lower serum calcium increases your parathyroid hormone secretion. And this is chronic and unrelenting. And so over time, you get four-gland parathyroid hyperplasia. And your PTH is continuing to be made in order to keep your calcium level in the realm of normal. Because you have parathyroid hormone that's overworking, you get increased bone resorption. And then so you also get calcium released and phosphorus released from your bone chronically over time. And this causes bone density problems as well as bone pain. So unlike the patients with primary disease, the patients with secondary disease due to end-stage renal failure have no catchy phrase to help you remember how they present. They're going to have oftentimes excruciating bone pain, and that's what they'll tell you the most. This bone pain makes it really difficult for them to walk or get out of a chair without having significant pain. They can have a lot of itching. On a DEXA scan, they will have osteopenia or osteoporosis, and they can also present with calciphylaxis, which is what we commonly call calcific uremic arteriolopathy, so little deposits in the skin that oftentimes people will confuse for small abscesses. So, patients with end-stage renal disease on dialysis will oftentimes develop secondary hyperparathyroidism. And we do know overall that there are some consequences to not treating these patients. So, there is a significant increase in all-cause mortality in this patient population if the parathyroid hormone level is greater than 600. For patients who are getting a transplant, a PTH of greater than 65 is associated with an increased risk of graft loss and an increased risk of patient death. So the stakes are still very high, even though these patients present with perhaps less overwhelming symptoms than the patients with primary disease. So the initial treatments for secondary disease in this setting are all medical. So these are things that the nephrologists are managing. And these include phosphate binders. So again, you bind the phosphate, this frees up some of the serum calcium. You give a lot of vitamin D supplements so that people will help absorb their calcium that they're consuming. And you also give calcimimetics. Cinacalcet or Sensipar is the most common one, and these function by binding the calcium sensing receptor on the parathyroid gland. This tries to tell the parathyroid gland to decrease the release of parathyroid hormone, and this leads to ideally up to a 50% increase or decrease in the parathyroid hormone levels. There are some side effects, particularly nausea and vomiting, and concerningly, this doesn't work in up to 30% patients. So if medical treatments are the first line options, what about surgery? When do we operate? And we operate in a few settings. First, the failure of medical therapy. So if a patient is on maximum medical therapy, they've altered their diet as much as possible, but their parathyroid hormone levels are still extremely elevated, that's considered a failure of medical therapy. If a patient can't take cinacalcet because perhaps they don't tolerate the nausea and vomiting associated with it, or sadly, sometimes their insurance won't cover it. Or if there's overt end organ failure. Now, you might be saying, well, hey, why do we wait so long to operate on these patients with secondary disease if an operation can fix this problem, whereas medication may not work? And the problem is that there's no good data to support one treatment option over the other, or to determine sort of a cutoff level at which a patient should receive an operation, unlike with primary disease. There's been no randomized controlled trials comparing medical and surgical therapies. There have been many large meta-analyses that suggest there is a mortality benefit to parathyroidectomy over medication alone. And some patients will see an improvement in their bone density and their symptoms. They'll see an improvement in their neurocognitive function, improvement in their overall quality of life following surgery that they wouldn't otherwise see on medication. And surgery oftentimes is more cost-effective than long-term medication. That said, there has been some literature showing that maybe there isn't a mortality benefit. Again, there's conflicting evidence there. And because these are dialysis patients, there's no safe operations for them. They have a high rates of post-operative complications, and some data has shown that their risk of readmission for cardiovascular problems within the year following surgery is extremely high. So we're having to weigh the risks and benefits of medication versus an operation in this patient population. So there have been some attempts at putting together some guidelines to help clinicians with these decisions. The Kidney Disease Improving Global Outcomes Consortium publishes guidelines every few years, and this is a figure found in their 2017 guidelines. And this just recommends parathyroidectomy when there's severe disease that's not responding to medical therapy. And then the literature that they also cite says, particularly if the PTH level is greater than 9 times the upper limit of normal. And again, that's 65. So we're talking a PTH level of ideally more than 600 is when they would consider recommending a patient have surgery. But there's other discordant guidelines from other national societies. In Japan, a PTH in the range of 60 to 240 is considered a goal. So anything above that, people start to think, well, maybe you should have an operation. In Canada, symptoms are really considered a trigger. Because of all these variations in guidelines, there's a lot of heterogeneity in the geographic rate of parathyroidectomy worldwide and even in the United States. So really, what happens is you become dependent upon the nephrologists determining who is or is not a good candidate for surgery, who's failed their medical therapy. And so, oftentimes my colleagues and I will see patients not referred when their PTH is 600, as the guidelines might suggest, when their PTH is 1800, 2000, and continuing to get worse. So when a patient has been referred to you for parathyroidectomy for secondary disease, generally they have had a pretty thorough workup by the nephrologist that you don't necessarily or should not even repeat because there's going to be very little value. They should have sent over a long history of parathyroid hormone levels as well as calcium levels and a whole bunch of other electrolytes. You should get an ultrasound like you normally would to evaluate for concurrent thyroid nodular disease. But generally speaking, if a nephrologist thinks that this patient needs an operation, they probably do need an operation. So what operation are you going to do? There are a few options that we're going to discuss here. So one option is a subtotal parathyroidectomy. Now again, this is secondary hyperparathyrodism, which means all 4 parathyroid glands are equally affected by the insulting source, in this case, the kidneys. So you have 4 abnormal glands. You can do a subtotal parathyroidectomy that preserves one part of the gland in situ. So you're going to take out 3.5 glands. I say 3.5, but really it's more like 3 2/3 or 3 3/4. Your goal is to try to leave behind a remnant that's roughly 2 to 3 times a normal gland size. Preserving this one gland in situ means that ideally you have good flow to one parathyroid gland postoperatively, and this gland should function a little bit and mitigate some of the postoperative hypocalcemia. However, leaving a gland behind that may have a variable amount of function, or maybe you leave behind more than you thought you had, this can lead to a recurrence rate ranging anywhere from 5 to 80%, which is an incredibly wide range, and I think speaks to the poor data that we have overall. But it has a higher rate of recurrence, and if you have a recurrence, it's a hard operation to go back in and redo. Another option for these patients is a total parathyroidectomy with autotransplantation. So you take out all of the parathyroid glands, and then you reimplant a fragment of one parathyroid gland into either the forearm or the sternocleidomastoid. Again, there's differing preferences amongst surgeons. There's no one right or wrong answer here. But you're taking all of this tissue out and you're reimplanting a part of it. That tissue takes 4 to 6 weeks, maybe more, to actually really have an effect. So the patient is going to have really prolonged, profound hypocalcemia while you're waiting for any tissue to regain function. This has a theoretically lower recurrence rate than a subtotal operation does because you're removing all the parathyroid tissue. And if you do have a recurrence, you can usually localize it to your auto-transplanted tissue. So the operation itself is usually easier. Now, is one of these 2 options better than the other? And, hopefully you're not surprised when I tell you we don't know, because there's no good data comparing one operation to another. There's really no difference on meta-analysis between the 2 techniques with the rate of symptomatic improvement, the rate of recurrent or persistent disease, or the rate of reoperation. The biochemical profiles for patients following these surgeries are also similar. So again, there's no one right or wrong answer here for what operation you should be doing. However, the efficacy of both of these operations can be improved by simultaneously performing a transcervical thymectomy. And that's a part of the operation in which you pull a bunch of thymus up into the neck from the chest and you remove the thymus. And that is because there are small parathyroid rests, which are microscopic pieces of parathyroid tissue that likely migrated during embryogenesis, and these can function in the future in a patient who's going to have chronic stimulation of their parathyroid glands. So some literature has shown that there's an overall cure rate is improved following with when you add a bilateral prophylactic thymectomy, a cure rate of 94% versus 89%. And this is something that can be performed with both a subtotal resection or a total resection with autotransplantation. The last option for an operation for these patients is a total parathyroidectomy without autotransplantation. And in this operation, you simply resect all 4 parathyroid glands. You don't reimplant anything. You assume that they have small parathyroid rests in their thymus, and these will kind of do the work over time if needed. But these patients get pretty bad adynamic bone disease because they have no parathyroid glands to help mitigate their bone health. The other issue is that this is not an operation if a patient is a transplant candidate, because if a patient gets transplanted, their kidney function will return to normal and their parathyroid glands should also then return to normal. So you don't want to remove all of the parathyroid gland tissue in a patient who might get a transplant. The recurrence rate following total parathyroidectomy is very low, and again, just like a total parathyroidectomy with autotransplantation, they are relatively hypocalcemic and hypoparathyroid afterwards. One of the challenges with operating on these patients when you're trying to prevent persistent or recurrent disease is understanding how much parathyroid tissue you can or should take, or what their function is like, or do they have ectopic glands that maybe you haven't found. And that's because intraoperative parathyroid hormone monitoring has a less of a clear role in this setting. So in primary patients, you know that their goal is to get the parathyroid hormone level to drop by at least half and into the range of normal. And so, for example, if I have a patient with a preoperative level of 110 and I resect one gland and their level goes down to 20, then I know I've cured them. But there really is no way to know that in this patient population for secondary patients. And that's because, for one thing, the parathyroid hormone is cleared by the kidneys. And in patients who have poor kidney function, there's no good understanding of the kinetics of the parathyroid hormone to be able to anticipate when you would expect a drop by 50% or into the range of normal. And also, many of them present with such high parathyroid hormone levels, again, in the multiple thousands, that waiting for them to drop into normal might take a prohibitively long amount of time. So again, there's no clear data or recommendations about what your goal parathyroid hormone level should be at the end of an operation. Most studies suggest looking for a drop of 50 to 70% from baseline, and I think that's a pretty good goal. One study has suggested that having a PTH less than 60 on postoperative day 1 is predictive of success. So again, no clear guides, but I think if this is going to be a part of your practice, you need to try and figure out what you're going to do and do it each time so that you can be striving towards a specific goal for your patients. Now, postoperatively, these patients are very challenging to manage. They become profoundly hypocalcemic with calcium levels in the 5s, 6s, and 7s, and 7, in fact, is actually great. They need to be on round-the-clock oral calcium supplements. They oftentimes need to be on a calcium drip. They also need to be on calcitriol, and this is quite a lot to manage. They become very, very hypocalcemic, and again, they can expect to stay in the hospital for 3, 4, or even 5 days until things get kind of back to normal. And for this, they might need to be in a step-down unit for regular monitoring of their calcium levels, or maybe in the ICU, depending upon your individual hospital's abilities. So again, they're started on a lot of calcium, and they end up getting discharged on a lot of calcium as well, just trying to maintain their calcium levels in some semblance of normal. Many of them won't experience the symptoms the way the primary patients do, the symptoms of hypocalcemia. So they can have a calcium level of 5, 5.5, and be totally asymptomatic from it. So you just need to approach their postoperative care very differently. So just like with primary disease, what are their postoperative complications? We just talked about their hypocalcemia, and this is all due to their hungry bone syndrome. Patients can also become permanently hypoparathyroid, whether or not that was your intention. Perhaps you left a remnant behind but accidentally devascularized it. And lastly, patients can also get recurrent or persistent disease. So again, you may not have done enough. Maybe their parathyroid hormone level postoperatively is still fairly high, or over time their end-stage renal disease stimulates the growth of additional parathyroid glands sort of in those parathyroid rests, or biochemically their disease just recurs. So these can all be challenges postoperatively. Tertiary hyperparathyrodism, I'm only going to touch on briefly, but as you know, tertiary hyperparathyrodism occurs when a patient has had a kidney transplant and has not had resolution of their hyperparathyrodism. So in patients with tertiary hyperparathyroidism, they either can have persistent hypercalcemia after their transplant, or perhaps they have a period of normal calcemia and then they develop hypercalcemia. Either way, they have a high elevated calcium and elevated parathyroid hormone, and they generally need surgery pretty expeditiously, otherwise their graft function can become affected. So in the next several slides, I'm actually not going to go over them in detail. I leave them in here for you to peruse. I've summarized the different kinds of hyperparathyroidism in terms of their presentation, their biochemistry, and what operations you offer them. And I hope you find them instructive. Here, I differentiate out the different causes of primary hyperparathyroidism by primary, secondary, and tertiary disease. Here are the different biochemical profiles for those three types of disease as well. And this slide summarizes the role of surgery in the management of each of these diseases. If you want to learn more, and I really hope you do, I have referenced some very high-yield articles here on this slide. The first is the American Association of Endocrine Surgeons Guidelines for Definitive Management of Primary Hyperparathyroidism. And again, I cited those a couple of times in this lecture. I think those are some really fantastic guidelines for how you should be practicing care for parathyroid patients in this day and age, and very high-yield reading. This next article is a recent summary article published just a few months ago, and I think also a great overall summary that gets a little bit more into the nitty-gritty rather than just providing some bullet points the way the guidelines do. And this third article is an article about how to perform parathyroid 4D CT. It says it's tips and traps for technique and interpretation. I just think that's a really useful way to understand how they're running the scan and also how they're reading the scan. And that's for 4D CTs that many people may not be as familiar with. Thank you so much for your attention. I know that was a lot of information I threw at you, but I hope it was useful, and good luck to all of you.